I'm Chris Danford. I'm a second-year resident at the University of Wisconsin Family Medicine Residency Program in Madison. And I'm here with John Beasley. Dr. Beasley is a professor of family medicine and coordinator of the iPractice Collaborative, which is an initiative that spans the University of Wisconsin Department of Industrial and Systems and Engineering and the School of Medicine and Public Health.
Correct.
John, we spend a lot of time training future physicians in medical knowledge and procedural skills, but not a lot of time teaching information mastery or how to use the new technologies that are really integral to patient care, with the result that there might be rapid changes in the way that we deliver care that happen in an unexamined way. And there might be efficient and effective technologies, like for example dictation, that are lost. I know you're a big proponent of dictating in the presence of the patient. Why is that?
Well, I think there are two parts to that really, and the first part, and maybe the most important, is dictating at all, because that's when you form narrative and you think through things and you create a narrative note that hopefully will make sense to your partners. The part about dictating with the patient is it gives them a chance to understand what your thinking is, to validate it or correct it if need be. And really, to me, it's both a time and money saver too.
In the sense of time, how much time is saved?
A lot. I can give you a micro experiment I did with a patient of mine who is a post-hospital follow-up, late 70s. He had 7 concurrent comorbidities, but I had 30 minutes, so I wasn't time pressured with him. And the dictation, which was part of that 30 minutes, was 3 minutes and 33 seconds to do his note. Then out of curiosity, once the note had been transcribed by UW, I went back and I typed the same note myself. And I'm good, I'm over 50 words a minute. And it took me 13 minutes and 20 seconds, 9 minutes longer to type that same note. And that wasn't composing, it was just transcribing. I then asked a skilled Dragon user to try the same note, and for him it took him a bit over 6 minutes, so still twice as long with Dragon as to dictate into a handheld device.
But there's always been the argument that transcription costs more.
Well, I would argue it probably really doesn't cost much more. That same note I described, the 3 minutes 33 seconds, was $7.72 that it cost UW to transcribe that note in exchange for 9 minutes of my time. That's probably, as this business goes, still fairly efficient. And then there may be costs to not transcribing. You can make the argument that, this is sort of back of the envelope stuff, but at least a rational argument, that if we were to give each full-time equivalent physician their own transcriptionist or the ability to dictate, that it would increase the throughput enough for the organization to come out over $20,000 a head a year after you paid for the transcriptionists.
Wow. You specifically like to transcribe in front of the patient.
Exactly.
Why do you do that?
Well, again, I can get feedback from the patient, I can get validation from them and I really often will stop and I'll say, did I get that right? Was that 3 months ago? Because other questions will come into my mind. I'm sure as you know from doing your own notes, sometimes you're halfway through the note and you think, oh darn, I should have asked about X, whatever X was. Here I just stop and I say, what about X? And they can tell me. And at the end I say, did I get all that right? And again, they begin to notice that I covered 4, 6, or 7 problems, that they begin to understand the scope of what we did.
Are patients comfortable with you dictating in the room?
Certainly anecdotally they're very comfortable with it, and I get a lot of positive feedback from that. What I don't get, or have looked for but haven't really found, are good RCTs showing. It's only one that I know of and showed, yes, patients like it. But there's really very, very good literature on the whole subject.
What if there's something sensitive that comes up during the visit?
Well, the patient always has access to the information in their own chart anyway, so if they want to see what you put down, and here they know exactly what I put in. And so I'm able to, just kind of say, I think the patient's problems are related to their excessive alcohol consumption. And kind of the flip side of that is the patients, we do know from a number of surveys, are very concerned about the confidentiality and what goes into electronic records. And I tell them a lot of times, if there's something that you don't want to go into the record, but you want to tell me, you let me know, and I'll leave it out. And I do. And I just put a little marker to myself that, yeah, we discussed other issues, something like that.
So what does this really look like?
Well, I can certainly show you right now. We'll just pretend for a moment that you're a patient of mine, and we'll make you a 50-some-year-old man, and we'll start out. The first thing, Ms. Danford, I normally dictate all my notes. I kind of like to do it right when you can listen in, and your job is to listen in and correct me if I make any mistakes. I used to use a little tape recorder for that, but I got to be all fancy and digital now. So let me dial up the transcription service here. There we go. I'm going to put in my codes and then your patient number. Dictating now on last name Danford, D-A-N-F-O-R-D, first name Christopher. Date of birth is 1/5/1958, period. Mr. Danford returns at our request for follow-up on problems of hypertension, diabetes, and some eczema, period. Overall, things have been going well for him. He's got a new job, has been more physically active, and he and his wife are exercising more, period. Problem number 1, hypertension. This has been long-standing, but under relatively good control with hydrochlorothiazide and metoprolol, period. His home blood pressures have had systolics floating in the 120s to 130s. He's had no orthostasis, no cardiovascular symptoms, period. His blood pressure today is about 132/80, period. Objective on examination, the chest completely clear, heart has regular rate and rhythm without murmur, rubber gallop, extremities are without edema. Assessment stable hypertension. Plan, we're going to ask him to return in 3 months with a BMP prior to that and probably also do a lipid check then. Problem number 2, diabetes. He was diagnosed with diabetes approximately 3 months ago at that time.
Actually, it was more like 6 or 8 months ago.
Oh, was that 6? Okay, good thing. Correction, he was diagnosed with diabetes approximately 6 to 8 months ago. Period. Started on metformin 500 milligrams 3 times a day, which is really tolerated well without GI side effects, period. He's increased his exercise to 45 minutes a day with his wife. He's watching his diet more carefully and has lost approximately 6 pounds in that time period. His hemoglobin A1C has dropped from 9.5 to 7.6. Period. To brief examination, the sensation of his feet is intact, period. Assessment, we're coming to goal here. Plan, we'll follow up in approximately 3 months with a hemoglobin A1C prior to that. Problem number 3, eczema. This has been well controlled with triamcinolone. We'll refill that prescription for him. That sound about right to you?
Yep.
Okay, thank you.
Oh, that's amazing. And the encounter now is done.
And encounters, well, I might have to drop the charges or something pretty trivial, but for all practical purposes, I'm done.
I think that's really amazing. Dictation is a lost art for our residency training now, and so I'm really glad that you'd share it with us.
Happy to.